mortality, CDI, and coding, right? Comparing data sets from our presentation piece today. And just to give, a backdrop on the two individuals collaborating on this, Amy Czahor, really great experience, currently, system director of inpatient coding operations, but, 17 years of coding, audit, and CDI experience, worked in all settings, which is great. I think that these types of individuals that we do bring, within these networks and having that experience from, an overall perspective is really what allows us, to get into some really good dialogue and conversation and obviously emphasis on process improvement and technology optimization, which, definitely comes kind of, within this presentation, which is fantastic. And then also moving on, to Alan Frady, auditor, educator, managing consultant. Quite honestly, in talking with Amy and Alan yesterday, I feel like I've known them forever. And quite honestly, I feel a large catalyst of that is just because we have, something common to talk about from a discussion standpoint. 21 years of total coding and documentation experience, 6 years of CDI consulting, 4 years as an active CDI trainer, 2 years as a coding director, 700-bed academic facility, 10 years in the contracting, industry from coder to auditor and trainer, 7 years of total direct nursing experience as well from that clinical side. So, again, really just parlaying off earlier comments, just, the overall background, within these individuals for, putting on these presentations and events is something that we're very, very proud of, to allow them to bring their experiences to that. So, without further ado, happy Friday, Alan and Amy, and by all means, the floor is yours.
Happy Friday indeed. I want to return a thank you to MedEvent. It's amazing how fast this thing came together. So we're honored that we were able to do this and get us on here. Good way to kick off the weekend. I do want to point out that our presentations, if you're familiar with Amy and myself, tend to be more conversational. So we won't be reading. The good news is we won't be reading these slides directly to you, and we may not hit every single bullet point. We want to very quickly get to the conversational points that are really the take home and the key takeaway type of thing. So without further ado, I'm just going to dive right in. I do have one other thing to say. There are two presentations here. We're going to spend predominantly most of our time talking about this first set of objectives, which is quality. The second one is kind of an in the news. It's about the dissolution of the CMS 3-day inpatient only procedure list. We'll try to hit that as best we can, but we may skate through it a little bit because we are also blessed with having a couple of excellent panelists, and we want to have some back and forth at the end. And I think what I'll do is have the panelists introduce themselves when we get to the panelist slides at the end, and that way I can just sort of keep on going. So let's just jump right into the quality metric. I wish I had set up a poll, and it would be, I would love to know from the group here, how many CDI encoder programs, training, conversations are starting to surround what to me are two of my biggest areas that I think about a lot in terms of what we can impact, and that is the readmission measures and the mortality. But if you're talking about quality, there are so many things you can be talking about when it comes to quality, and there are different vendors and different metrics. And what we have on the slide here is really the CMS sort of performance payment measures, which includes, I've got some of these broken out, and I've got some of them by the high, the overall general category like value-based purchasing, but it also includes healthcare associations, patient safety, complication measures, readmission measures, and mortality. Also, Medicare spending per beneficiary, days in hospital. And today's focus will be on mortality, but we could just as easily do a very similar presentation for both readmissions and complications. And what would largely change would be the type of diagnoses that we pull and try to dig into. A couple of talking points here is nobody is purposefully lowering these scores, at least not anymore, to try to increase case mix index and grab a complication or index something into a mortality via query. Nobody's doing that on purpose, but we think it probably still happens inadvertently because this is an unusual practice for CDI. And one of the goals when we were looking at this is to at least begin the conversation about how CDI encoding will start to work a little bit more synergistically, in this case with quality in terms of mortality metrics, and a lot of educational opportunity here in terms of getting the physicians to understand how this works, works, and it's different from our traditional CDI coding for case mix index. So let's talk about a little bit further into what this impacts. So if you're looking at just the mortality by itself, you're going to hit all four of these circles. So you're going to increase your, this is an interesting thing, you're going to increase your CMS star ratings, of course, we know that's the core of this, but you're also going to increase things that you may not think about, which is your RAP scoring, as long as they're still using RAPs, RAPS, for HCCs, and they still are, even though I think it's only 25% this year. Whenever you add these adjusted, sort of risk-adjusted mortality diagnoses, they're HCCs, so you may very well be adding to that portion of the score. In doing that, you will also, in many cases, get an improved payment through CMS incentive program payments, and you can look that up. Most of the time, that's publicly reported information. Just as an interesting talking point, if you're wondering who the highest performer in the country, the last time I looked, Mayo Clinic, which is a large system, but overall, they were the biggest beneficiary of maximizing quality in that they were getting, and I don't remember what the most recent year's data was. It was available. It was either, I think it was 2019. But they were getting like $4 million in incentive payments. So the average hospital gets, I want to say, anywhere between 200,000 and 300,000. Maybe a good hospital will get 500. But we also see a lot of hospitals that lose 2, 3, 4, and even $500,000 on these programs. So not huge money in terms of the millions of dollars that we talk about a lot of times in coding and CDI, but still significant. And the last one is driving traffic to your hospital, which is there's, even though all of these methodologies are different, there's a lot of overlap. So all of them may look at pneumonia or sepsis or MIs, even though they have other things that they look at are different. So once you start optimizing one, you'll start to see a creep in your other vendors. So you got things like Elix Hauser, Vizient, Premier. I'm sure there's others out there, and then of course the CMS Gold Star. So you'll start to see that. And for those patients who are a little bit more tech savvy and who are following that, it could help drive traffic to your facility, which is going to become more and more important talking point to your CFO. All right, so let's just jump in. I'm sure Amy may have some talking points here about what are the challenges in working on mortality sort of philosophy when you're talking CDI. And those challenges are that the specific diagnoses, and I'll show you some in a few minutes, are not things that are traditionally thought of at all in terms of maximizing your case mix index and maximizing your DRG. Things like cachexia, and I know Amy has some comments on that. You don't typically think about cachexia or ear, nose, and throat diagnoses that may be risk adjusting in a stroke patient, so they can be missed. Lack of specificity. I've got another grid coming up that I think is going to dive into the lack of specificity a little bit more. Aggressive query tactics. So everybody wants to turn everything into sepsis, right? If cellulitis, it's sepsis. You can, for example, Premier has a mortality cohort for sepsis, and you can start putting patients in that bucket whenever they should have just been in a different bucket because they meet the old SEP1 criteria. And we're not here to talk about sepsis. Certainly, Lord knows we could, but those kind of things are worth taking a second look at, I should say. So chronic conditions oftentimes go missed in the inpatient setting. You got your acute this and your acute that, but we didn't get the diabetic linkage, we didn't get the major depressive disorder recurrent, whatever it is. Those things fall through the cracks all the time, and those things, again, those HCCs, are risk adjusters for mortality, and they're also risk adjusters for 30-day readmission and some of these other things. So confusing and conflicting documentation, we all are familiar with this. The H&P and progress note says one thing, the discharge summary says something else, or the final progress note, and maybe it was there, but guess what? It's not going to be reported. So that's something that we really, I think, struggle with, and it's also something that we need to micromanage as an industry, especially when we start doing quality stuff. So let me pause there and let Amy jump in.
Yeah, I think one of the things, especially as we get into the actual case examples, specifically from a coding perspective, we're all trying to optimize that DRG, and we're all trying to, increase and maximize that severity of illness and that risk of mortality in our encoder, and from the APR DRG system. But I think, as Alan pointed out, we're going to see things that don't really factor into either changing the DRG, the SOI, or the ROM that are extremely important from a risk adjustment perspective for mortality. And so just sort of not just always focusing on DRG validation and, you know, going with the encoder and saying it's at a 4.4, I can stop. It's really sort of shifting gears and data mining and making sure that you're extremely familiar and you're auditing and holding coders accountable for capturing all of those risk adjustment codes as well. So it's a kind of a shift in philosophy when you really start bringing in these quality metrics and how your coding and query practices influence those.
Yeah, thank you, Amy. Just before I go to the next slide, these are the measures that we looked at for the CMS star ratings and, you know, Medicare performance pay incentives, except sepsis. Sepsis was a premier metric, and I'll show you, this is one we looked at in particular was premier, so we've added that. But typically you would see CABG, heart failure, stroke, pneumonia, COPD, and AMI. Subject to change year over year, of course. Pneumonia actually counts two ways, as principal or secondary. But let's get into, oh, I may have actually removed, no, it's coming up. Okay, so let's get into some of our findings. And this is where I really think the most take homes are for me personally, which is that we looked at a small sample of records just to get an idea what was going on. And we found that up to 50% records that we looked at, while they were pretty good as far as the MSDRG, still had untapped significant risk variable findings that would impact either Premier, CMS, or both that were left on the table. They're not exactly low-hanging fruit, and sometimes it takes more to get to them, but they're there, and it appeared that they were present. In some cases, they were even documented, and we just didn't get them. So that's pretty significant to me. I'm not saying every facility is missing half of their cases, but if we found that, it's pretty significant. The next thing, which is really significant to me, is that only 1 out of 5 cases, if you're using 3M risk or mortality to model out when a record deserves a second review for misdiagnosis, that would only have popped up, that would only have overlapped in 1 out of 5 cases. In other words, 4 out of 5 times, you would have had a risk or mortality of 4 and still be missing risk variables that you could have picked up for CMS and Premier. And a lot of that, some of you may know, just has to do with present on admission. Present on admission gives you full credit, whether it's present on admission or not in 3M, but in a lot of these things, including Vizient, you don't get credit for it unless it is present on admission. So there's a disconnect between using 3M's risk or mortality as a model for when you need to do a secondary review. And that's something that we should talk about. I've got a workflow later on. 10% of the cases were moved into the Premier sepsis cohort by query activity. Just be careful. Make sure if you're doing that, it's legitimate, and you didn't, if you're really interested in Premier, make sure you didn't accidentally index a case into a mortality bucket that shouldn't have been. 7% of the cases were known palliative DNR patients who did not have that hospice. And for CMS, it's not an exclusionary issue unless it is hospice within 12 months prior to up to the day of admission. And so could we have fixed this? Remember, not every family is ready to have this discussion. I'm not going to sit here and say that number will ever be 0. But could we do better than 7% if we were a little bit, I don't want to use the word aggressive and death in the same kind of context, but if we were a little bit better at having those conversations with families and letting them know what the true outlook is, you know, what the real down low is, so to speak, and that, you know, it's time to have that discussion and maybe consider that decision. I think we could get down that percent. It's a hard discussion, and 7% is not bad. I think we could get that to a better number still. And then 10% of these cases, interestingly enough, for the 2020-2021 cycle, 10% of them had COVID either documented or suspected, but no lab tests. We didn't get the U07 on the chart, whether this was earlier in 2020 or what happened. So I'm hopeful that 10% of your cases and your bumps in mortality attributable to COVID will be sort of transient and will go away as COVID goes away. So those are pretty significant findings. Pro-fee, this was something we did that was unusual. So when we go look at pro-fee, typically we're doing a pro-fee audit, but I wanted to see if there were discrepancies between pro-fee, what the doctor was reporting, you know, for their pro-fees that were occurring during the inpatient stay, and what the facility coding was. And what we found was at least 20%, so 1 out of 5 cases, had kind of mixed signals that what was in the pro fee did not match what was in the professional fee. And I got some examples. So 3 cases in which there was a lack of pro fee documentation that may have contributed to the facility not picking it up. And those 3 examples were pneumonia, upper GI bleed, and COPD with O2 dependence. And this will happen because whoever the particular doctor is, if he's not treating, evaluating, or monitoring that direct diagnosis, or if it's resolving or somebody else did it, she won't put it in their note. And it may have very well been present, and it may very well be enough clinical support to report it for the facility. But now we got a conflict because I can't bill it for my E&M level today, and it drops. And so I wanted to see if that was happening. And it happens in up to 20%. Now we also found 2 cases that may have actually been overcoded on the facility bill, where the physician did not document anywhere severe sepsis with shock. And I'm sorry, I don't want to sound negative, but I have to wonder if aggressive query activity created that situation where the doctors really didn't think it, didn't bill it, but the facility did. That's a disconnect that I'd want to get to the bottom of. And stroke, present on admission, I think we over-reported that on the hospital bill. One case which was completely missing coronary artery CAD with unstable angina, it was just CAD. And we think that the physician behavior may have contributed to she not writing that in the chart either, because again, they weren't working it up in their fee. This is that conversation of, it's not just about what you do today, it's about all the care that applies to the facility and all the ancillary staff and all the work and supplies and everything. If there's legitimate diagnoses, we need to report those for the facility bill to capture all of that. Doctors get stuck in only what they do, and it causes a lot of misses. So root cause, this is where I said I had some additional examples sort of coming up that would come up. So under lack of specificity, I saw some things like NSTEMI due to demand being used, an outdated term, instead of a type 2, or major depression unspecified, patients had it 10 years, instead of major depression recurrence. Hard to get on inpatient side, but they were definitely dropped, and they definitely would have risk adjusted. Present admission I already talked about with 3M. I'm jumping around. Let me get my cursor over here. So, and then misconditions, things that are suspected and not worked up. You'll see that a lot in death cases where they died during that admission because they're quickly transitioned to sort of palliative. And once again, since the doctor's not treating, monitoring, it's out of sight, out of mind that the nurses is having to do the care, or the supplies, or the type of bed they're in, or whatever's going on, would have justified reporting the condition. But because they didn't get it for their E&M leveling, it just drops. And you probably see that a lot with patients whose status change pretty quickly. Inconsistent documentation, of course, one doctor calls it, whatever, pancreatitis, another calls it sepsis. Those are going to make conditions drop because we don't know what to code. It's unclear. Sometimes we can clarify, sometimes we can't. I already talked about putting patients into sepsis when maybe they just, I don't want to start this debate, but maybe they're just SIRS, right? And now we dump them into sepsis under SEP1, but it was really mild and everything they had was expected. And now we've got them in our premier cohort. And then maybe they go home and die of a GI bleed. It probably shouldn't have been in that cohort, but it is. So we see that happening. Atypical. So this is where I also said I was going to have examples. Things like acidosis, cachexia, skin, behavioral, musculoskeletal, vision, and vascular, none of which I particularly went after very hard whenever I was just doing inpatient CDI for the MSD or G, but all of which, well, it changed not only your mortality scores, but hospital readmission reduction program in some cases. And then lastly, rapidly resolving conditions that resolve either in the ED or just after the ED that nobody's talking about in their note, again, because they're only talking about their E&M level for today. They just drop off the documentation. Probably would have been ethical to report it. I mean, we need to beef up our documentation, but we could have done it. They just drop. So let me pause here again for Amy. If I seem like I'm going fast, it is on purpose.
No, I'm good. Just a reminder on that resolved conditions, there is that coding clinic that confirms that it is okay. And it's actually a mortality case. It's an expired patient that they use as that case example, that respiratory failure documented in the ED by the ED physician, never mentioned again, is still codable secondary diagnosis. So just a reminder that that's sometimes on these patients, we are drilled in through the denial process that, it wasn't consistently documented. I need to query for it, but it wasn't really treated on the inpatient side. It was treated in the ED. So just, again, remember that official guidance. I use it in every appeal where they've used that rationale that it wasn't consistently documented. Again, if they're denying on the basis of coding guidelines, I provide that official guidance as rebuttal.
Thanks. That is actually, I think, one of the most underrated, under-talked about, maybe not even known about coding clinic, is that respiratory failure resolving in the ED. Coding clinic says, yeah, you can still report it. Let's jump to our findings real quick. So we looked at 6 of those cohorts. The first 3 are up: heart attack, COPD, and heart failure. And I just want to kind of show you 50% of our heart attacks had a missed opportunity, which was, one was a GI malignancy and the other one was MDD recurrent. The GI malignancy, and I'm doing this from memory, but if I recall, the patient had been refusing to get it worked up and that caused a snag. And the MDD was just documented as unspecified. We all know that's a problem. However, both of these were 404 and 3M, and neither one of them would have caused a secondary review. But one of the 2 diagnoses increased the Premier score from 0.86 to 1.23. Jumping over to COPD, we had 3 out of 4 records with opportunity. We had like 5 opportunities. That's because a couple of these records had more than 1 opportunity, so that's how you get 5 and 3. All of them were 4 out of 4. None of them would have generated a secondary review using that methodology, but they were core pulmonale. Some of these are kind of significant. Core pulmonale gets missed a lot because there's a whole cause and effect sort of pulmonary specialty to it. Pneumonia is an HCC 116, right? And all of these are HCCs, by the way, as well. PVD, emphysema, and a left bundle branch block. And you can kind of see how separately getting emphysema, because there's a coding clinic about it sort of being part of COPD, and something like PVD in a patient who couldn't breathe and died, how those things would start to drop. It's important to just realize what's in this methodology and try to work out when we can separately report things. Even when there excludes ones, there are some occasions when we can separately report. The Premier scores on 2 of these 3 jumped up. Remember, the methodologies don't perfectly align, but they do overlap. So on one case, it went from 196 to 263, and on another one from 1.26 to 1.66. Heart failure is an interesting one. 2 out of 5 with opportunity. They were COPD and AKI. Ouch. Both of those seem like they should have been picked up, especially with O2, dependence. But patients die quickly and things drop. One of these actually would have generated the secondary review. It was only a 2 and a 4, so half of these would have. But the real kicker for me in the heart failure population was that both of them had what I call sort of complicating circumstances, in that one of them was a DNR coming in, but we didn't get them on hospice. And the other one, COVID-19, was pretty well documented, but we weren't able to cash in on the U071. U071, by the way, is an exclusion. I can't remember what date that kicked in, if that was September. At some point during the year, U071 became an exclusion, and they maybe even backdated it to where if you did have a mortality, but you had U07 on the 01 on the chart, it was excluded and was not in the cohort. It didn't hurt your scores, at least for CMS. Let's do the last 3 and then I'll pause again. So next up we have pneumonia, 3 out of 8. I looked at more pneumonia records because there's more of them and there's a lot going on this year. And also pneumonia counts a couple of different ways. And 3 of these were an MI that was caught an NSTEMI, so we missed it. We missed our 86. And there was actually a couple cases like that, but I've only counted it once, but there was 2. And then anemia of CKD, anemia of chronic kidney disease. That's that linking specificity, probably just had CKD. And then acute liver failure, which, those liver enzymes spike and it just doesn't necessarily get picked up because the patient's dying and it just doesn't get separately worked up by, a specialist. All of these were 404, would not have generated a secondary review. COVID-19 suspected, I think that was a liver failure one that didn't get further worked up. And querying for sepsis, moved this over. What it was sepsis with secondary pneumonia, put the patient in the cohort. Now, if we hadn't had that, they would have been over in the pneumonia cohort anyway as a principle. So that's interesting. But all 3 of these improved the scores, and I'm not going to read these scores to you, but you can see the jumps. Each one of these improved the Premier scores. Sepsis is next with 3 out of 4 opportunities. Interesting case. All 3 were cachexia. And that's something that when I looked at it, I was like, wow, I really hate to count that. But in some cases, cachexia is reportable, even whenever they have other diagnoses present that you might, and Amy's going to talk about this, that you might think are sort of integral to it. 2 of the cases wouldn't have gotten a secondary review. 1 of them would have. But look at what cachexia does to Premier. I mean, it really jumps it. 0.56 to 1.3, 0.21 to 2.77, and 5.39 to 8. Now, I don't know what Premier's doing. Sort of wanted to ask them what they were doing, but that's interesting. And if it's a score you're interested in, then I think by default you have to be kind of interested in cachexia. Lastly, a stroke, 2 out of 5. They were GI bleed and cerebral bleed. And you can see that one of them would have still generated a secondary review. And stroke present on admission, whether it was present on admission or not, was a stumbling block here. But both of these improved the premier score pretty significantly. So there you go. You can see there's a kind of a lot to this. And if I had Vizient and Elix-Hauser out, running down the bottom, you'd probably see changes in several of those as well. Amy, do you want to jump in here?
Yeah, absolutely. So I think when we talk about mortality, we haven't really discussed yet, but everything I'm sure you're all familiar with hearing, what is our O to E, right? What is our observed to expected ratio? And so typically when we start focusing on mortality and how we move the needle, we tend to be hyper focused on the observed. And here's the thing, you're really not going to be able to change your observed. The patient was admitted and the patient expired. Now, you can obviously make sure that they have the accurate principal diagnosis sequencing so that they're in the right cohort. You can make sure that their, ROM is maximized in the encoder. I think Alan's shown how sometimes, that may be a red herring. We probably should be looking at our cases, our expired cases that are 4/4s just as closely as we are those that are under. But I think where the mortality conversation shifts is that we have to change our focus from that observed number that we're not going to make smaller and really focus on that expected number. And what's driving that expected number is your denominator. It's your entire patient population. So when we look at these things where, we're looking at a cohort and let's say there's 50 observed, right? There were 50 expirations. What we really need to focus on, and in order to drive up that expected number to a significant level, we have to start focusing on ensuring that all of these risk adjustment variables are captured on the entire patient population, the entire cohort. And so it's not about focusing on the numerator, it's about focusing on the denominator, and it's denominator management. So, and again, instead of focusing on those patients that expire, to really significantly move the needle from an O to E perspective, you've got to be maximizing the risk adjustment on every single patient that falls into that cohort that is discharged alive. So I'll stop there, Alan, and get your feedback.
So this was an aha moment. It was so far in the back of my mind that I really wasn't thinking about it, but it's almost more important that you grab all of these diagnoses on your patients who live. And it's not just if they live or died during that admission, it's patients who live or die anytime during 30 days post-discharge. So our population of interest just expanded infinitely because we need to make sure these risk variables are captured on every single patient, even if they're a 404, even if they live, even if they're healthy, because that is what is going to adjust your denominator. Your denominator is not controlled by just the ones who did die. It's controlled by all of the risk variables in the population, even the population that lived. So suddenly this effort just got a whole lot bigger in terms of making sure, I guess the takeaway from that would be anybody who is significantly, no, not even anybody who's significantly sick, right? Anybody who has significant evidence that some of these risk variables may be getting missed, they need to be gone after. If you really want to do what Mayo did and make 4 million, I'm not saying you can make 4 million the way Mayo did, but if you really want to, reach for that brass ring, that's what you have to do. You have to make sure you're not missing any of these. So thank you for that, Amy. That was a huge sort of aha moment / talking point, I know for me at least. Let's jump to real briefly what some of those examples were. I already kind of touched on these, but in the pro-fee, for example, if some of you were wondering, I wonder what some more detail was about the pro-fee. So I have that here. The AMI example, you can see the doctor, and I may have said it, if I said it slightly different, it's because I was probably thinking of a different case. But on this one that's documented, the doctor billed for CAD and unstable angina, but CAD stable was what we got on the facility bill. To me, that says that's a miss. You know, if the doctor thought it was CAD with USA and there was any kind of evidence at all in the facility bill. So this is something we don't do a lot. We don't go back and look at what the doctors are billing, but I think it's a worthwhile spot check. On the COPD, we think that I had to go get an outpatient risk adjustment coder who does this every day to tell me what they thought. Two heads are better than one, as they say. And we thought maybe it was skipped because it was, probable in the ED, and that multi-lobar was completely dropped, and then it wasn't picked up till later. So we ended up with a present admission of no, when there was clearly evidence of it, and that was that prophy, because he just didn't, for his prophy, he just wasn't really making it clear, and then it wasn't made clear in the record until much later. It was probably there. So you get the idea of what's going on with some of these. The intern doctor did not document the decline of the patient status, did not indicate the cause of death. What happened? Sudden change to DNR. They're not treating, monitoring, evaluating, and all of those diagnoses just suddenly disappear, even though they're present. Remember, that might be fraud for the doctor to pick up if they don't treat, monitor, but it is not fraud for the facility to pick up if it meets one of the 5 reportable things, nursing services being one, increased length of stay being another, which are likely to be getting impacted. So again, a lot of confusion, I think, between prophy rules and the IPPS definition of a secondary reportable diagnosis for the facility. Liver, none of the providers here billed septic shock, although we got it on the HB, and I just can't help but wonder if we queried and somebody just said, yeah, do it, but none of them really thought it was present. Again, I think these need to be looked at a little closer. Upper GI bleed, patient had hematemesis, they were working them up. It was documented. But this was one where the patient, I don't think they ever fully got it worked up. And so it looked like we maybe could have gotten it under the probable or evidence of rule, uncertain at the time of discharge, but we just weren't able to. And then lastly, we billed a stroke present on admission, but none of the doctors on the case billed a stroke until the day of death. There was a lot of evidence in the record. The patient did not have a stroke until day 3. So we put this patient in a stroke cohort for mortality when they shouldn't have been, because it shouldn't have been the principal diagnosis. So let's jump really quick to, my mouse is not cooperating, to a generic workflow. Briefly, a lot of you, at least I know I did at multiple facilities in my years as a contractor, would go and say, okay, risk of mortality less than 4. Yes, okay, well, that needs a secondary review. It goes back to a code or it goes to somebody else. If the risk of mortality is not less than 4, it'll just got the coding finalized. But I've added additional thing, which was, is there a possibility of a CMS index mortality? Is it a cabbage patient, a pneumonia patient, a sepsis patient? Is it one of those cohorts? And then are we checking to see if we picked up everything? So in those cases, it may need to go out, and the coder may just simply look at that. Oh yeah, that cachexia is reportable. They can add it and we can move on. They may say, oh, I'm not sure. Let me send it back. It's going to go into swim lane, a CDS, or a physician advisor is going to look at it, and then they're going to make the decision whether to hand it back to be finalized or potentially to put it back out into the circle for queries. Does it need to go to the physician advisor? Does it need to be routed up this way directly for a query? And I've got this extra little physician advisor in here because you may get, if you have bad quality problems with a particular physician, then that may need to be in yet another swim lane of, like any other escalation for a potential problem in a behavioral issue. So I've got that in. This is just for the problem cases. And then of course query and then back to billing. It's really just a modification of the standard thing that you would do if the risk of mortality was less than 4, except now it includes looking at CMS adjusted mortality. And here's where I will come out of the presentation for 1 second, see if I can do this without being too messy. Some of you are probably wondering what I'm talking about. So I've got on the screen, this is directly from IRQ, hospital inpatient quality, and this tells you what an index case is. This is strokes. And if they have one of these as principal diagnosis, they're in the cohort now. The clock is ticking for 30 days. And the way to improve that, whether they are live or die, as Amy pointed out, is to make sure that all of these stroke mortality risk variables, if they're present, get reported. And remember, I said we probably don't do a good job of getting PVD or 108. That's valvular, but I think 108 is in here. I'm just kind of going pretty quickly. We probably don't always make sure that we get, here it is. There's the PVD, and eye, nose, throat, and mouth disorders, a risk adjuster for stroke. I bet we don't get that a lot of the time. We probably don't get that on our records. Did we forget to pick up something like, I'm looking to see what other things I think might get missed. Stroke patient, cerebral palsy. Well, did we miss that because it was masked by the stroke? Hemoptysis, we always try to get that even when it resolves before discharge. Other musculoskeletal though, maybe they have some kind of just simple musculoskeletal problem that would have been an HCC 45. So you can see where a lot of this stuff would get missed. This is the over and above stuff that might not have anything to do with getting a risk of mortality of 4 or a CC or MCC on the chart. Totally different data set. And then they have to be present on admission, yes. Only if occurring, not used if it only occurs during the admission, meaning it had to be present on admission, yes. Can't get PVD hospital acquired, and hopefully you wouldn't, and expect it to count. Renal failure happened during the stay, not going to help. If they come in with acute renal failure, it helps. So now present on admission becomes even more important than it already was. So I just wanted to show that very quickly. In case you were wondering sort of where I got my information, all of that is publicly available and the links are in the presentation. Actually, right here. So midpoint, we've still got to talk about the inpatient 3-day only, but I will entertain just to give everybody a quick breather, 1 or 2 questions if anybody has them, or if anybody has 1 or 2 questions, or if Amy wants to jump in.